Good morning, everyone, and welcome to the Compass HIIN Learning Community. My name is Katie Bodenhauer, and I'm the Education Director here at IHC. Before we get started today, I want to walk through a few brief housekeeping items. Attendees on this webinar are automatically muted. However, we highly encourage you to interact and ask questions during the event using the chat box function, which can be accessed by clicking the chat button on the bottom of your screen. We have Compass HIIN staff members monitoring this chat box at all times. We will have a video in today's event, so please ensure that you are using either your phone or computer audio, not both, as you will encounter an echo if you have both enabled. This webinar will be recorded. Information will be shared in a follow-up email on how to access the recording and slides from today's event. 2.3 nursing contact hours are available for this learning community. In order for nursing contact hours to be awarded, you must have provided your nursing license number at registration and be logged in individually from a computer or laptop for the full duration of the event. You must remain logged in for the whole program, as no partial credit will be granted. A nursing contact hours continuing education certificate will be emailed to you 2 weeks after the webinar. You'll receive an email with a link to complete an online evaluation of today's program. Please take just a few minutes to complete this evaluation. At the end of the evaluation, you will be able to print off a certificate of attendance that can be used for all self-reporting continuing education credits. IHC encourages you to also keep a copy of the learning community agenda with the certificate for your record. We have a great agenda lined up today. We're going to start with a telepsych panel, then move on to the health equity organizational assessment, and then finish up with the community and hospital partnership. It is my pleasure today to introduce Sandy Atkinson, Clinical Quality Consultant for the Compass HIIN, who will introduce and moderate our first session.
Thanks, Katie. Good morning, everyone, and thank you for joining us today. Recently, Iowa Healthcare Collaborative has had facilities ask about telepsychiatric services. Questions that arose include how services are implemented, are there requirements, such as conditions of participation, how are staff impacted, and what is the perception of telepsychiatric services from the patient and the family? Has there been a decrease in mental health patients since the services started? Iowa Healthcare Collaborative felt that the virtual learning community was a good platform to hear from facilities who have implemented these services and provide information on the setup and use of ER telepsychiatric services. The hospitals will address the above questions. We have a speaker to address community perspective on benefits of telepsychiatric services as well. It is my pleasure to introduce Addison Enns, Greg Opseth, Katie Helt, and Bob Lincoln, the presenters for our first session. Addison Enns is the care coordinator and oversees social services at Guthrie County Hospital. Her role is to ensure all patients receive the treatment they want and deserve and assist patients with improving their well-being. Addison holds a bachelor's degree in sociology from the University of Northern Iowa and a master's degree in social work from the University of Southern California. As a social worker, she strives to ensure all patients go to the least restrictive destination within their scope of abilities. Greg Opseth is the Chief Nursing Officer at Guthrie County Hospital. He works with nursing staff at Guthrie County Hospital to create an environment which fosters teamwork and collaboration to best advocate for and promote the health of patients. Greg received a bachelor's degree in psychology with a minor in Spanish from Buena Vista University and a bachelor's degree in nursing from Nebraska Methodist College. He received a master's degree in healthcare administration from Walden University. Katie Helt is the Chief Nursing Executive at Greene County Medical Center. She holds a bachelor's degree in nursing and a master's degree in health administration. Katie has been a nurse for more than 30 years, working in rural and tertiary facilities. Prior to assuming her role as Chief Nurse Executive, she was the Trauma Program Manager for Unity Point Health, Des Moines. She has a wealth of knowledge regarding behavioral health issues for critical access hospitals and was integral to bringing telepsychiatric services to Greene County Medical Center. Bob Lincoln is Regional CEO for the County Social Services, Mental Health, and Disability Services. In this role, he oversees the building of supportive communities for individuals with disabilities in 22 North Iowa counties. Prior to his current role, he served as the Director of Central Point Coordination and Targeted Case Management for 5 Iowa counties. Bob launched the first START team, which is specialized mental health intervention for individuals with intellectual disability and mental illness, in 2015. He launched the first Crisis Stabilization Center in Iowa in 2012 and co-chaired the State Mental Health Redesign Committee. I want to take this opportunity to say welcome to our presenters. The first presenter will be Katie Helt with Greene County Medical Center. Katie, take it over.
Good morning, everyone, and thank you for that wonderful introduction, Sandy. Pleased to be able to provide information about telepsychiatry at Greene County Medical Center today. So next slide, please. So just to give an overview of what Greene County is, we're a 25-bed critical access hospital. We are located in Jefferson, Iowa, which is about an hour and 10 minutes northwest of Des Moines. We are an affiliate of Unity Point Health, and that is beneficial to us, so we're pleased to have that partnership. Currently, and at the time of working to implement telepsychiatry, we, sorry, I have to mute this, hold on. We are using a service that we contract our ED physicians to provide care for our ED patients. And this is a wonderful service, but as you can imagine, these ladies and gentlemen do not have psychiatric experience. They were unfamiliar with what the process should be to provide care for the mental health patients who present to the ED. So not only do these physicians currently provide ED service, they are also our hospitalists, which means they provide care for our inpatients. So they have a dual role, and as you can imagine, with a lack of mental health training, it became very cumbersome for them to assume all of these responsibilities. We had no telepsych, we had no mental health provider locally. We were doing many of our patients a disservice, and I know this will sound familiar to anyone else who's in a critical access or pretty much any other healthcare facility. Patients show up, they have a need, they have a mental health need. We don't have the appropriate beds, we don't have the correct provider, and so ultimately they were either committed, which is not a good use of resources and not the proper placement for the patient, or we just held them until we could find proper placement. So as you can imagine, and I know many of you have experienced this, it takes many, many phone calls and many, many hours to find a bed for these behavioral health, mental health patients. And I'd like to comment on a misnomer that there are plenty of mental health beds. While that may be true, there may be plenty of mental health beds, but one mental health bed is not one size fits all. It takes a variety of beds to accommodate the variety of needs for these patients. We also at Greene County had limited outpatient resources. We had no outpatient mental health provider, and like many of you, we faced a transportation issue. So people would come in, we would be able to treat them, or they would be transferred, or whatever that looks like, but yet they couldn't follow up appropriately because there were no outpatient resources to appropriately follow up. So as you can imagine, these people would return and end up back in the emergency room, which is not good for them and not good for the facility, and just not how proper care is delivered. Next slide, please. So what we when we considered telepsych, what had happened was Ann Erickson, our acute director, had attended a meeting in Des Moines, and we learned that we were a member of a region. We had no idea that we were members of a mental health region. We had not, for whatever reason, had not known this information. And then that allowed us to figure out, okay, what can we do to assist our patients? How can we work with the ITP, which ultimately became our provider, to provide evaluation and find proper placement for these mental health patients rather than committing them or discharging them or whatever they looked like. One of the challenges for us was that we were not familiar with telehealth, and we very rarely use telehealth. We used it somewhat in the clinic, but we had not used it in the emergency department or on the inpatient side on a routine basis. So not only did we have to get the staff buy-in for that, we had to work with our providers to show them that, yes, this is another provider and they are trained in mental health, this is a benefit to you, et cetera, et cetera. The other challenge for us was how would we document appropriately in our electronic medical record, which happens to be Epic, because there still has to be documentation regardless of who's taking care of the patient, be it telepsych, be it locally, whatever that looks like. And then we had to work closely with our IT to ensure that we had proper connectivity. And was the connection secure? Were we going to be able to secure the electronic medical record? Was it safe from a HIPAA perspective to take care of these patients? And so what we did was we developed a mental health coalition as a response to this. And we collaborated with other county entities such as the jail to access ITP as well, so we could promote consistency of services. And I will talk a little bit more about that in just a moment. Next slide, please. So before we went to the telepsych care, we looked at our mental health volume in the ED. And we had to figure out, you know, when are these patients primarily seen? And we all know that in the ED that's unpredictable, but we looked at an average. And what type of patients were we seeing? And then we looked at the resources that we were currently using, like I spoke about earlier, these hours and hours of phone calls to try to find placement, working with the county attorney for commitment, et cetera, et cetera. And what efforts were we expending to find placement for these patients? We looked at the cost and inflammation of telepsych. So prior to knowing that we were part of a region, we also looked at other options for telepsych, and it was cost prohibitive, to be totally honest. The benefit would have been great, but it was cost prohibitive for us. So we were very, very fortunate to learn that we were part of the region and that the telepsych services would be provided to our patients as part of our region. The community health needs assessment or community needs assessment, which every facility does, was identified that there were a lack of mental health services, and that was not new. That had been on the community needs assessment for years. So we knew the need was there. It was just how could we best address it. And like I spoke about earlier, we were improperly placing these people. We were wasting resources, and we were taking beds that may not have been the correct placement for our patient. Next slide, please. So this is when we began our ITP services, and this is just a snapshot number of cases. And you can see on here the cases that are most of our patients were mental health inpatient at that time, 57, almost 58%. But the most astounding statistic to me was that a lot of these patients, rather than just our ER providers saying, well, I'm not sure what to do with them, so we need to commit them, we're able to work with ITP to arrange outpatient follow-up for them. So almost 33% of our patients were able to be served through outpatient rather than be sent to a bed unnecessarily. The other win for us is the median placement time. And what this means is when we enlisted the services of ITP, they actually did the calls for us. So a provider would evaluate the patient via telepsych through ITP, work with the ED provider, and then ITP would take the onus to make the calls and find the bed for the patient. So the median placement at that time from May of 2017 to December of 2017 was a minimum of 3.68, almost 4 hours, which is much better for us than 2 or 3 days. So next slide, please. So as you can see, we stayed pretty consistent. The other thing that we added was we were able to add an outpatient mental health provider at our facility, and the provider is there every Monday. And so we were able to meet that outpatient need to a point. There's of course still need for more, and I think there always will be need for outpatient mental health, but these are our statistics from January 18 to December of 18. You can see our median placement went up a little bit, just a little over 7 hours, but you can also see that our volume went up to 96 patients. So once again, it's about half-half, inpatient 47, almost 48%, and then outpatient went up to almost 44%. So we continued to work with ITP, became more familiar with the providers that we were using, and we feel really good about making sure that our patients are getting to the proper placement in a timely manner. Next slide, please. And this is the most recent statistics that we have to a point. You can see January to March, and we already have used ITP for 24 patients. And once again, the statistics remain very similar. Median placement time is down just a little bit, 4 hours basically, but the volume isn't the same. So I don't know that we're currently comparing apples to apples. My point of showing you these slides is that it was a good thing for us that it allowed nurses to be able to take time to provide care for patients rather than being on the phone and trying to find placement. It also gave the ED providers the peace of mind knowing that there was a mental health professional evaluating these patients and determining what the proper care for them was. So this has been a win-win for us. Next slide, please. So as I talked about, in 2017, we established the Greene County Mental Health Coalition. That is in partnership with our local mental health representative from the county. Also, we had law enforcement, we had ITP at the table, we had our county attorney at the table, we had many other people at the table. And like I also spoke about, ITP was not only implemented at Greene County Medical Centers, but it was implemented in the jail. Because what we were seeing was people were having mental health issues in the jail, and they were just, to no fault of theirs, the jailers were bringing them to the hospital for treatment. Well, what a great saving of resources for them as well, to be able to have the ITP services at the jail and be able to keep the jail folks in the jail for those services. It was a lot of transportation issues and things like that were being avoided, so that we felt that was a win. And as I talked about, we started outpatient mental health services. And then in 2018, we actually left the Heart of Iowa region and transitioned to the Central Iowa Community Services region. And we have had a lot of success, continued success since we've gone to our new region. It has been a win-win for us to work collaboratively with our mental health coalition, to work with the region, and also to work with ITP. Next slide, please. So as I mentioned, ED providers now have a resource to assist in the evaluation of mental health patients. It's not their expertise. Most of them are family practice providers. So now they have a mental health expert to help them with these patients who present to the emergency room. ITP has assumed responsibility for locating appropriate placement. And since we've established our mental health coalition, we have much better collaboration and knowledge regarding our resources are available. And what this mental health coalition really did was improve our conversations with each other. There was a lot of finger pointing and a lot of, you're not doing this, well, you're not doing that, why aren't you doing this, et cetera, et cetera. But by bringing everybody to the table and having similar resources and standardizing processes, we have seen great success with our mental health patients. And last but not least, ITP is a great partner to work with. They've been responsive to our requests. They provide us excellent quality improvement parameters, data, and any other data that we have requested. So that's all I have, and I look forward to your questions at the end of the presentation. Thank you.
Thanks so much, Katie. That's great information to share. Addison and Greg, I'll let you take over.
Thank you.
Thank you.
Good morning, everyone, and thank you for attending this morning. We're going to go through a little bit about our story with ITP. Next slide, please. So much like Greene County Medical Center in Jefferson, Guthrie County Hospital is a 25-bed critical access hospital in Guthrie Center, Iowa. We are roughly 45 miles to the west of Des Moines, and we ultimately established with ITP in August of 2017. And prior to our implementation with ITP, we also faced many of the same challenges that Katie alluded to during her time. However, in the same year that we implemented ITP, we actually were fortunate enough to recruit a psychiatric mental health nurse practitioner who began services in an outpatient capacity here at the hospital full-time. And she sees patients on an outpatient basis and then also does inpatient and ED consults. So when we were able to onboard with ITP, this was a great supplement to our already established service line with outpatient mental health. One thing that differs Guthrie County Hospital from Greene County is we do not have a hospitalist model. So our primary care providers cover the emergency department, the clinic, as well as cover inpatient medicine as well. Next slide, please.
So this is Addison. So starting off with the key considerations, the first thing that I want to point out is the ED and social services staff time that has been consumed prior to ITP services being implemented. So much similar to what Katie had reported for Greene County, is extremely time consuming. As the care coordinator and social worker in this facility, it was primarily my responsibility when we would have an individual come in who was requiring placement or who we suspected was requiring placement. So it would be my duty to be calling, the 30+ facilities across the state of Iowa, looking for open beds. And also, like what Katie said, there might have been many open beds, but they might not have been suitable for our specific individual. So on top of, the hours of making phone calls, completing paperwork for places, which would be different forms for every unit that we would talk to. So each unit that was considering accepting a patient, I would have to fill out a different document or different set of forms on that patient for those facilities and send those off accordingly. So while I was in-house, which I am a Monday through Friday care coordinator, we do not have a 24-hour social worker at our facility. So while I was in-house, it was my primary responsibility to be doing that. At times, it could take an entire 8-hour shift that I was here, and then if it was not, if placement was not established while I was in-house, it would then become the nursing staff's responsibility. Which during after hours and weekend hours, it was the nursing staff's responsibility anyways. Since we are such a small facility, we do only have one ED nurse on staff at a time, and then we just get assistance from our inpatient nursing staff if necessary. So if that responsibility was placed on the shoulders of the nurse in the ED, it can be extremely difficult for them to provide appropriate care to other patients if there are other patients being served in the ED for other health concerns. So it had to become a team effort to make sure that the appropriate care was being provided for all of our patients so that placement could be secured as soon as possible. Like I said, it could take entire shifts for nursing staff, for myself as the care coordinator and social worker, and so bringing ITP on board has been a big benefit, and I will get to that here in a little bit.
Next slide, please. So much like Katie mentioned during her session, we also were unaware that we were part of this Heart of Iowa Community Services region. And when we learned of that and the ability to partner with ITP, it became very evident that this was the route we needed to go to better serve our patients that we see in the ED. But one of the big hurdles that we had to overcome was really identifying transportation, because initially, once we found a bed, we were still challenged with how do we get the patient from our ED to that inpatient facility. And initially, we were still utilizing EMS, which ultimately is unfortunate when they're oftentimes going across the state and therefore taking EMS out of service for a good portion of the day. So about 6 to 8 months into our time with ITP, we identified a secure car service that we contracted with, who we now refer our patients to for transportation. So once ITP has identified a bed for us, then we are able to fill out a referral form for the secure car transportation company, and within a couple hours, they're on site to pick up our patient and transfer them to the appropriate facility. And the key about the transportation, and one of the benefits to this, is that is also part of the agreement with the region. So at this point, the identification that we are part of this community services region has absolutely benefited not just the hospital, but ultimately the patients and the care that they need to have in that period of time. A couple other considerations while we were looking at the business model was IT equipment. We were fortunate enough to have a lot of telehealth equipment. We had cameras already available to us and had a couple service lines in the outpatient sector that we were utilizing telehealth for, but this really gave us an opportunity to truly utilize that equipment to a different capacity. So our IT and the IT staff from ITP worked very closely and were able to ultimately make this a seamless transition. We had multiple calls, we had multiple trial runs, and once we went live, it actually was pretty seamless. And as ITP updates their platforms, they are very good about educating and sending that information out to all of their organizations that they service. And the staff education piece at the beginning was extremely simple. We were able to do that electronically, and staff were able to do it on their own time with a specific deadline before go live, and it really was a seamless process. Next slide, please. So some barriers and challenges. So this is both pre and post in ITP implementation. With the committals, that becomes a dicey situation, because if our ITP provider determines that the patient does not need inpatient treatment, but we have a committal stating they do require inpatient treatment, that becomes a very slippery slope to traverse with the county magistrate. So that's an important challenge to keep in mind as you might be considering this implementation. And even after going live with ITP, as Addison mentioned earlier, our nursing staff are still responsible for those facility intake forms. So as they identify these facilities that may be able to take the patient, we as the originating facility are still responsible for filling out those facility intake forms. And as we all know, those forms are all asking for the same information, but we're filling it out redundantly. So that's one thing that ITP is working very diligently to try to make a form that's more uniform across the state. That's not the case yet, but that's the direction we're all hopeful that we can go. And then secure car transportation, as I noted earlier, it was very difficult to call EMS and say, we've got a patient that we need to transfer up to Sioux City and take them out of service. So identifying and ultimately securing this transportation service was extremely beneficial. Next slide, please.
Okay, so starting off discussion about our facility successes with ITP, I want to point out the appropriate use of our in-house social services. So that's where I step in again as social worker and care coordinator in our facility. With ITP being implemented, I no longer have to dedicate all of my time, or really any of my time, to trying to secure placement for an individual that we are serving. This allows time for me as a licensed social worker to be consulted in the ED for our patients. So if a patient comes in and is, belligerent for whatever reason, having a mental health crisis, This allows for me to be consulted to support that individual and to use my professional knowledge in using crisis intervention for a patient rather than sitting at a desk and a phone making a bunch of phone calls. So it really allows for my education and experience to be put to better use. This also allows time for just my regular social service responsibilities, whether it's on the floor or in the ED with other patients. So I can assist with committals or voluntary cases, like I said, if crisis intervention is needed. If a patient or a family member needs any counseling or education while in the emergency department waiting on placement, that's a service that I provide, and I'm able to do that now that my time has been freed up and allowed to provide that service. If we have a juvenile or an adolescent that comes in and they have a parent with them, we have had situations where children do have to be placed, whether it's a committal or voluntary on the parent's decision. I am available to support the family in those aspects and step in and talk with the child and with the parents or the guardian, whoever is with them, to make sure that their needs are being met and that they are comforted while they are here. As you know, having a mental health situation in the ED can be extremely taxing on everybody, and just being able to provide whatever support I can is beneficial to the patients we serve. And I appreciate very much being able to use the ITP so that I can appropriately provide my own services.
All right, so some more on our successes here internally at Guthrie County Hospital. Much like Katie described for Greene County, we at Guthrie County have experienced much less time spent in the ED with these patients. ITP has expedited the process for placement and ultimate discharge, and that has been a true asset to our organization and the patients. A big key for us has been the continuity of care, because as I mentioned, with our psychiatric nurse practitioner, we're often able to, if at all possible, if the patient's going to be discharged outpatient, that we ensure we make that initial connection in the ED with our provider, so that if that patient's not already established with her, the patient has the opportunity to meet her face-to-face prior to making that appointment and ultimately seeing her in the outpatient area. Obviously, as Katie mentioned as well, we had no issues with provider buy-in. When we described the platform and these resources, the providers were absolutely on board and simply just asked what they needed to do in order to execute this plan. So that was a very simple sell. And the same with the ED staff and truly the entire nursing staff. When we rolled this out and educated them on the service line and helping them understand that they were going to have the ability to not make those phone calls and be burdened with that side of the patient care, they were extremely pleased, and it has been truly a seamless process since go live. And ultimately, this has afforded us the opportunity for an improved protocol. It didn't matter which provider's on duty. It doesn't matter where the patient's going. We know that when we have a mental health patient walk in the door, we have a specific set of labs and different procedures that have to be done in order to medically clear them. We forward that on to ITP, and then we maintain communication in that way. So we're very, very pleased with our launch of ITPs thus far. Next slide, please. So ultimately, what has this ITP afforded us from a service line perspective? Just to recap, we've seen a decreased burden on our ED staff as well as our social worker. We've also seen a decreased consumption of services because we have resources at our disposal and are able to appropriately align these patients with the resources that they need in real time. And as mentioned previously as well, in the community, we're affording these patients expedited access to services that they might not otherwise see. We're not keeping the patients in our ED for 2 and 3 days, but able to get them out within hours. And because of the presence of a mental health professional internally, we're able to offer them real-time access via ITP, but also face-to-face with our professional here at Guthrie County Hospital. So that's what we have from Guthrie County Hospital. We're happy to answer any questions and look forward to assisting how we can. Thank you.
Thanks so much, Greg. Great information. Bob, I will turn it over to you to speak from the community aspect.
Yes, thank you. And thank you, Katie, Greg, and Addison. I've learned so much in listening to you, and so excited to hear how this service has been implemented. The regions are, it's easy to make the investment and put the tools out there, but what you've done to implement them and change the lives of folks in your community is very impressive. And to really see the hospital, really the hub of our rural communities, expanding their capacity to serve folks with mental illness. So kudos for your great work. I'm also pleased to hear and join in the cheerleading with ITP. We have history with ITP. Doug Wilson, about 5 years ago, Renee Schulte, Representative Schulte, introduced me to Doug, and he told me of this plan he had to deliver telepsychiatry, and he had struggled launching it for the last couple of years. And in my community, when we had stakeholder meetings, there was always the cry, we don't have prescribers, we don't have prescribers, we can't get people in. And Doug came to one of those meetings and stood up and he says, I can get you as many prescribers as you want. And he's delivered on that, delivering services to the jails, to your hospitals. And so again, so proud of his success and his growth. And again, moving that capacity out to the community so people can recover in their community. Next slide, please. So county social services, yes, there are regions out there. I was amused to hear that you discovered yours. I'm now a little self-conscious. I don't know how many people know that they're in county social services, but we're a 22 member county mental health and disability services region. We were established in 2009 with 5 initial counties, but then with the mental health redesign in 2013, there are now 14 regions. So if you don't know, you are all now in a mental health and disability services region. Our charge, historically, we were the primary provider. County funding provided most of the long-term support for folks with mental health and disability services. We now have moved Medicaid back to the state, and we have a much smaller pot of money, but now our charge is to provide a safety net for individuals with disabilities and to increase community capacity. So what I'm going to talk about today is we're committed to getting the services started to get the capacity, but then we're going to have to depend on that third-party payer, certainly Medicaid, to sustain these services long-term. Next slide, please. So the way we view the critical access hospitals and your role in the system is access points. There's been a lot of conversation with House File 2456 that set out a whole continuum of new infrastructure for mental health services. But again, you have a unique place in the community, being that healthcare hub. So you're the perfect access point for when people are not well. They should know and be welcomed at your hospital as I know they are. This map shows what the county social services implementation looks like for those access points now. Unity Point does provide telepsychiatry in our Berry Hill catchment area, Pocahontas, Humboldt, Webster, and Kossuth. And then beyond that, ITP is providing that access. And I'm pleased that in 2 of our counties, they actually have two locations. What we envision going forward then, once you have them in the hospital, and again, I just was so impressed to hear the conversation about people don't always need a bed. And it's very nice to hear that language changing, that people need help. They need what they need, when they need it, and how they need it. And putting somebody in a bed oftentimes means we're taking them out of their community. We're shipping them to Council Bluffs or Davenport. No offense to the folks in Council Bluffs and Davenport. That's the right place for folks living there. But for folks who are in Mitchell County, to be transported across the state to receive intense treatment, to start a relationship with a provider, and then to be discharged, never to see that provider again, obviously does not lend itself to the continuum of care. So again, that's what's so exciting about your role, is you are that provider when they have a medical illness. You can now be that provider when they have a mental health illness. And we know a lot of things by just providing a safe sanctuary. Folks can recover and use their skills to get back home and back in the community with your help. So from those access points, then you're hearing a lot of conversation about access centers. What's confusing to everybody when we talk about access centers, everybody pictures it being a place, and certainly there will be centers that will be access centers, but access centers are really more of a concept of how do we triage, how do we assess, how do we get people where they need to be. And so House File 2456 has identified at least a minimum of 6 access centers throughout the state. And from my perspective, their primary role is to divert folks out of that law enforcement involvement, to give law enforcement another option besides the emergency room and besides jail, where people can be welcomed and receive access to their mental health treatment. Then from these access centers that will be staffed 24/7, and their deliverable will be getting law enforcement in and out as soon as possible. No eject, no reject, always having capacity or being able to transfer people on once they're dropped off. And then also connected to our wonderful psychiatric inpatient units for those folks that are exceeding their capacity to care. But within those access centers, or within that virtual arrangement, we'll have crisis stabilization, we'll have subacute, and certainly mobile response will be some of the glue that holds a lot of these services together. Next slide. So again, to give you some perspective, if you didn't know where the inpatient units are, again, we do have certainly a concentration of beds in the Polk County and the Johnson County area, but you can see as we get out into some of the rural counties, it's obviously going to be an issue of transportation and getting access to those psychiatric units. What we envision doing with the access centers is in no way competing with our private psychiatric hospitals. In fact, what we want to do is refer the most appropriate folks, and for those folks that are law enforcement involved or court commitment involved, we can maybe take some of that pressure away from our psychiatric units so they can provide good voluntary access to services. Next slide. So then in terms of discharge and follow-up, our mandate as regions is to provide that follow-up within 10 days. So again, keeping that communication with you as hospitals so that when we know somebody is transported to an inpatient unit, we can start working on that discharge. And we can bring them back to the community to make sure they're connected. County Social Services is invested in strength-based case management, the University of Kansas model. That's the best way we think we can provide rural access to kind of that full social service intervention until we can get folks on Medicaid, until we can get them hooked up with our provider network that then is able to provide more of that long-term care. Next slide. This just shows you some of our utilization experience. Again, happy to see it moving up, and then that gives us an opportunity of what is the need, and then how do we move from these crisis points into the community to maybe create better capacity. County Social Services is scheduled to launch mobile response in January, so it'll be very interesting. We're one of the late implementers of mobile response. It'll be interesting to see what these numbers, how they respond when we have mobile response available. But the other, I think the other interesting point that we don't want to lose in this this graph is that 25 to 35% of this population were individuals under 18, and again. With the children's mental health bill passed and moving forward, it is a great time to now, once we're connecting with these young folks in crisis, we start building out that system of support for them. Next slide, please. So again, in terms of sustainability, it's costing the regions about $450 per episode to have that 24/7 psychiatric service available through ITP. Again, we think it's a good buy, but then how can we sustain it, and how can we make sure we're not leaving any third-party reimbursement on the table? So what County Social Services will be doing in this round of our contracting is trying to bring our community mental health centers in as the primary contractor, and then bringing ITP in as a subcontractor to provide that service so that they can use the medical record of the mental health centers. They can access that continuum of care more seamlessly in terms of that outpatient services. And again, like I said, making sure we're getting whatever third-party reimbursement that we can. We know, or at least I do as a region, that will never be sustainable on the third-party reimbursement, but we want to bring that third-party reimbursement so we can reinvest it. Next slide. So I think, again, I talked about this, and again, that's going to be the key to sustainability. Always is, how can we make sure insurance is paying? Do I have one more slide? Value added. Again, I think you've all hit these points, so I won't belabor the point. I do want to challenge you to look at 23-hour observation in holding. It is reimbursed by Medicaid at $414. I think with ITP and with your medical beds, this would be a perfect service, so that, again, we're not even sitting people in the ED for 4 hours. We're moving them right into holding an observation. And I know some of you have already been practicing this model. I think that would be the perfect fill, so people aren't, again, I think about law enforcement. They said, with folks with mental illness, it's all about slowing down the response time. And I think that's the challenge for you in the emergency departments. How do we slow down our response and give folks time to recover? I'll stop there. Thank you.
Thanks so much, Bob. It looks like you've got a great influence going on in your region of Iowa. So I just want to touch on, these are some resources and funding opportunities that we have been able to come up with. We have not researched them, so I will leave it in the hospital's hands to do the research to determine whether there's funding available to implement telepsychiatric services. It looks like we do have several questions in the chat box, and I know, Greg, you have gone through and answered some of those, but what I'm going to do is read them aloud so those folks that don't have access to computers can hear the information as well. So the first one is, what does ITP stand for? It stands for Integrated Telehealth Partners. There's been a question about, what are some options for secure car transportation? Greg, I know you and Addison had spoke to that. Can you address that quickly?
Yes, we utilize Central Iowa Juvenile Detention Center out of Eldora, Iowa.
Yeah, that's kind of an interesting history. When we opened our crisis center in Waterloo, it was actually half of the juvenile detention center that hadn't been used for 2 years. And we just kind of fell into the notion of this transport because the detention centers were already transporting youth. And so then we just expanded that. And so now I know that North Iowa Juvenile Detention and Central Iowa are offering that transportation, and that is something that regions have been reimbursing.
Great, thank you. Another question is, how are these services explained to the patient and the family when they're in the emergency room? Katie, do you want to address that?
Sure. We use a similar process to how Greg responded in the chat box. It's about introducing, the provider actually explains to the patient that he will be consulting with a mental health professional, and how the telehealth will be used. Brings the screen into the room and says, this is the person, you know, that will be evaluating you, et cetera, et cetera. And, you know, I have to comment that we actually had a mother of a pediatric patient who came back after her daughter was treated and came back and said to the acute care director how happy she was to have somebody available to take care of her daughter, not have her daughter sent somewhere, but actually just make a medication change and be discharged rather than go through the whole long process of finding a bed, et cetera, et cetera. So for us, introducing the patient and at times parents to the process it is what we do, and it has been very successful for us.
Great, thank you. There's been some questions about how financially this is taken care of. Is it billed to insurance? Is it billed to the county coalition? Greg, would you want to address that?
In our situation, Guthrie County Hospital is not billed for the service from ITP. That is between the region and ITP.
Okay, thank you. So does the insurance company then pay for the telepsychiatric services to the patient?
So,
No.
So with our Unity Point locations, that is being billed, and there is a third-party reimbursement. With our arrangement with ITP, they are not currently a provider, and so they are not any billing they do it as a subcontractor through another provider. So that may change in the future. All
right, thank you, Bob. There's been a question about how consents are handled for this type of service. Do you require a separate consent? Is it just part of your general consent to treat? Can one of you elaborate on how that's handled?
So at Guthrie, we received verbiage from ITP and incorporated that into our general consent form in order to not have an additional consent form to be signed. And so that's when we introduce that we're consulting with ITP, we reiterate that that is what we're doing. So that's how we handle the consent. And all of that was provided to us by ITP.
Okay, great. Thanks, Greg. So there's been a question about getting provider buy-in. So can you elaborate, Greg, on what types of things? I know you said that you had explained to the providers, I believe you said that you brought ITP in to allay their fears, but there's been a question placed in the chat box where a facility tried to implement it and they did get pushback from the providers. So can you elaborate on that just a little bit more?
Sure. So I do believe that we are unique from the perspective that we actually have two nurse practitioners who both have their certification as psychiatric mental health nurse practitioners. So I think that alone was a benefit to us because they both have inpatient and outpatient experience. They both had worked with ITP in the past. So I think that alone was a benefit to us. However, even extracting that component, as soon as we told our ED providers that we had this resource available and that all we had to do was demonstrate medical clearance and we could turn over the coordination of services to ITP, there was no reluctance whatsoever from our providers. In fact, it was, when can we start, and let us know what we need to do. So from our perspective, we had no pushback whatsoever.
Great. Thanks so much, Greg.
I would just comment too. I think, again, you know, it's easy to add that service, but again, changing the culture, making people with mental illness welcome, and the training and the awareness that goes into is really going to make the difference in how well this service serves your community.
I would agree with that, and I just want to echo what Bob just mentioned. I think that prior to ITP coming on board, I think there was a sense of discomfort or not knowing really how to handle these situations because the staff were so inundated with responsibility for not just basic nursing care, but now we're burdened with trying to find a bed. We're trying to find transportation. Now we need to call back in 20 minutes, call back in 3, 4, 6 hours, and we're trying to juggle all of these things. And now the nursing and provider staff are able to extrapolate that from their responsibility and truly focus on the care that they need to deliver. And that has truly been a benefit once we've embarked on that with ITP.
That's neat. That's great.
One question that I have for you, Greg, is so you bring ITP in to see the patient when they're in your emergency room. At that point, when they make the determination that the patient is stable, shall we say, and they try and find placement, does the patient then become a patient of ITP, or does the emergency room doctor continue to serve as their provider?
No, the ITP provider is simply a consulting provider. They do not assume care in any capacity. So our provider internally is responsible for maintaining assessment and evaluation of that patient throughout the duration of their stay. So once the patient is ultimately discharged, they add that to their note in terms of disposition and plan. So to answer your question, ITP does not assume any direct care of the patient. It's simply in a consulting platform.
Okay, thank you. We've got about 1 minute left. There was another question that had come back asking about what's required for a patient before they're committed through the emergency room. Is there special testing that's required? Can you elaborate on that for just a little bit, Greg?
Sure, no problem. So really I call it the pretty standard protocol. We have to get all the appropriate labs. They want to make sure that the patient's hemodynamically stable. We have to get an EKG. We don't have the ability to do a Tylenol level. That's often something they require, but we just simply note that we don't have that capability, and that doesn't ever seem to be a problem. And then once we also have to monitor their vital signs to demonstrate that stability. And then once we get all of that lab work back, the provider has done, our in-house provider has done their assessment and evaluation. Once we have all of that documentation, it's uploaded onto ITP's electronic platform, and then they're able to push it out to the appropriate facilities once they identify potential openings.
Okay, great. Well, I do see that we are at the top of the hour at 10 o'clock. I want to take this opportunity to thank Katie Helt at Greene County Medical Center, Addison Enns and Greg Opseth at Guthrie County Hospital, and Bob Lincoln. Thanks so much for your time today, guys. It's been a great hour, and we've had lots of good information. For the participants, we are going to take a short break, and our next session will begin at 10:15. Thank you.
Welcome back, everyone. We're going to go ahead and get started with our next session. It's my pleasure to introduce Michelle Bonson. Michelle serves as a clinical quality consultant for Iowa Healthcare Collaborative's Compass Hospital Improvement Innovation Network. She received a bachelor's degree in nursing from Chamberlain College of Nursing and holds a certified professional coder designation from the American Academy of Professional Coders. Prior to joining IHC, she worked for payers in various roles that involved clinical research, clinical and technical writing, identification of markers of quality for developing centers of excellence, provider payment strategies, new-to-market clinical programs, and employer benefit design. Michelle's clinical experience includes long-term care, inpatient mental health, medical surgical, and home health care. Welcome, Michelle.
Thank you, Katie, for that nice introduction. Good morning, everyone. As Katie said, I'm Michelle Bonson, and I serve as a clinical quality consultant with the HIIN program. So some of you on the call may be familiar with working with me. It's my pleasure to spend the next half hour discussing health equity, particularly as it relates to the hospital setting. At the end, I will have a special invitation to extend to all our HIIN participating hospitals. However, I want to recognize that we have participants on the call that are not hospital employees, and that's okay, because health equity reaches across all healthcare settings. My hope is that you learn something new and or gain insight into some of the work we are doing with hospitals as it relates to health equity. Before we dive in, let's just spend a couple of seconds going over the objectives for today. The goals are to describe the Health Equity Organizational Assessment, also referred to as the HEOA. We're going to review the 7 assessment categories, discuss the value of completing the assessment, and demonstrate how to complete the HEOA in the HIIN reporting database. Before we jump right into the Health Equity Organizational Assessment, I think it's important to set the stage via a review of the basic difference between equality and equity. As evidenced by this graphic, which I think provides a great visual, equality does not equal equity. Equality seeks to provide the same level and type of resources across population groups or areas, even when some are more disadvantaged than others. This leads to an underinvestment in strategies that would close gaps in opportunity. Equity, on the other hand, seeks to account for inequality by customizing the level and types of resources provided to eliminate disparities and ensure sufficiently similar outcomes for all population groups and areas. So, as we know, the quality of healthcare has been and continues to be a focal point. Hospitals play a very large role in this, as nearly 30% of personal health care spending is directed to the hospital setting. However, recent reports would suggest that significant disparities exist and have not been reduced in the last several years. This leads to increased harm, readmissions, longer lengths of stay, and unknown or poorly managed chronic health problems. I know that this is something that impacts all of our hospitals that we work with within the HIIN network, and so it's very important to kind of really take notice of the Health Equity Organizational Assessment and understand how that can help you in these various areas. So what do you think some of those disparities are? And you can use the chat box if you'd like. Yeah, I see Angie says language. That's great. Race. Thanks, Lana. Hi, Nancy. Yes, you're right. Ethnic and cultural groups. Structural racism, gender. You're getting all of them. Educational level, perfect payer source. Great. I think you guys hit on a lot of those. So some that I had were age, race, ethnicity, language, geographic setting, sexual orientation, gender identity, religious affiliation, and socioeconomic status. And I'm sure all of us can think of many more. Before disparity reduction efforts and interventions come into play, it's really important to know or understand your hospital's baseline, and thus the reason for the Health Equity Organizational Assessment. So what is this assessment? It is a tool that was created for HIINs and their hospitals to really evaluate and better understand their preparedness to address health disparities through the consistent collection of accurate demographic data, then use of that data to identify and resolve disparities, and then think of organizational and cultural structures to sustain the delivery of equitable care. The HEOA is comprised of 7 key categories that align with research in the field on where and how hospitals have the most impact to reduce disparities. And what I think is interesting on here, if you look at it, there are 4 pieces that have to do with data. And we all know in the absence of data, we really don't know which way to set our sails. So there are 4 sections on data. 2 of them have to do with collection and collection training. One is validation, one is stratification. Then there's the section on communicate findings, addressing and resolving gaps in care, and organizational infrastructure and culture. I'm going to switch over to a video tutorial that was compiled by our HIIN Health Equity Affinity Group. It provides a more detailed review of the metrics and the assessment itself. And I would just like to provide a gentle reminder right now that you double check to make sure you're either using speakers or phone, but not both, in order to decrease echoing during the video.
Hello, and welcome to the Hospital Health Equity Organizational Assessment tutorial. This brief tutorial will provide hospitals in the Hospital Improvement Innovation Network program, abbreviated as HIIN, an overview of the Health Equity Organizational Assessment, explaining the why, the what, the when, and the how related to HEOA. The Health Equity Organizational Assessment will be abbreviated and referred to as the HEOA during the rest of this tutorial. Why was this HEOA developed? The Hospital Improvement Innovation Networks developed the HEOA to better understand and assess the current state and ability of hospitals to identify health disparities in their organizations. HIINs are collecting the HEOA from hospitals as part of a broader pilot project. The intent is to use this HEOA to best provide technical assistance to hospitals and support hospitals in disparities reduction efforts and advance health equity. All HIIN hospitals are encouraged to participate in this HEOA. What is in this HEOA? This HEOA is exactly how it sounds. It is an opportunity for hospitals and health systems to assess themselves and become more aware of their equitable interventions or existing opportunities in an easy-to-understand tiered framework. There are 7 HEOA assessment categories, which you will see here on the left. There is an accompanying description for each of the 7 assessment categories, which gives you an idea of the intent for each one. The categories are data collection training, data validation, data stratification, communicate findings, address and resolve gaps in care, and infrastructure and culture. We will take a deeper dive into each of these momentarily. Each of the 7 assessment categories are broken down into 3 levels of hospital implementation, which include a basic fundamental level, a mid-intermediate level, and an advanced level. The HIINs understand that organizations may be at all different stages, which is why the HEOA was intentionally designed with a data collection assessment category is noted here at the top. Hospital uses self-reporting methodology to collect demographic data from the patient or caregiver. Hello, and welcome to the Hospital Health Equity Organizational Assessment tutorial. This brief tutorial will provide hospitals in the Hospital Improvement Innovation Network program, abbreviated as HIIN, an overview of the Health Equity Organizational Assessment, explaining the why, the what, the when, and the how
Hi everyone, this is Michelle again, and I apologize. It appears that our video is not wanting to cooperate real well today. We're having some difficulties with the buffering of it, so I'm going to try and walk you through this at a very high level, and I apologize because I think the video does a great job of explaining it, so I'll try to do it justice here in the time that we have available. So in the data collection area, and actually within all 7 categories, there are intents related to those. And so the data collection piece is really looking at hospitals and if they use a self-reporting methodology to collect demographic data from the patient and or caregiver. And in response, there are 3 different ways in which they meet that. There's a basic or fundamental way, there's a mid-level or intermediate way, and there's an advanced way. And so the basic or fundamental is that they're using self-reported methodology to collect race, ethnicity, and language data for all patients. Some of you may know that to be REAL data, R-E-A-L. And then when they move into the mid-level or the intermediate level, that means that they collect the minimum, and then in addition, they meet basic fundamental levels of implementation, as well as they collect real data for at least 95% of their patients, with opportunity for verification at multiple points of care beyond registration. And then the advanced section says that you meet the basic and the fundamental, as well as the mid-level or intermediate. And then the advanced means that you use the self-reporting methodology to collect additional demographic data beyond REAL for patients, such as you're looking at disability status, sexual orientation and gender, veteran status, geography, and or other social determinants of health or social risk factors. So just by way of making this a little bit more to the point, each of the 7 categories has the basic or fundamental, the mid-level and intermediate, and the advanced, and it's sort of a stair-step approach. And I think it'll be more visible when I go into the actual demonstration of it. So by way of just making up some time here, let's talk a little bit about just the categories themselves, and I think then when I go into the demonstration, we'll look at the different levels. So we talked about data collection, and then the second category is data collection training, and it's really looking for the hospital to provide workforce training regarding the collection of self-reported patient demographic data. And it's really important that they understand why they're collecting it and how it's being used. And then the third section is data validation. The hospital verifies the accuracy and completeness of patient self-reported demographic data. And if you think about this, a lot of this is interaction with the patient and or their family member. So this is not just looking at the patient and making a determination, but it's actual collection based upon the patient's response to questions. The fourth level is data stratification, and it's looking for the hospital to stratify patient safety, quality, and or outcome measures using patient demographic data. The fifth section is communicate findings. We want the hospital to use a reporting mechanism, for example, an equity dashboard to communicate outcomes for various patient populations. The sixth category is addressing and resolving gaps in care. So as you can imagine, once you have all that information, you're able to sort of implement interventions to resolve differences in patient outcomes. And then the last one is organizational infrastructure and culture. And that's looking for the hospital to have an organizational culture and infrastructure to support the delivery of care that is equitable for all patient populations. I'm going to go ahead over to our demonstration. So the Compass HIIN Health Equity Organization, each HIIN really, so there are 16 HIINs across the United States, that each HIIN is interested in working with their respective hospitals to complete the Health Equity Organizational Assessment. It's really a standardized assessment tool. I want to emphasize that there are no right or wrong answers. We really are looking for a good, solid baseline. And for those of you who are the HIIN hospitals and use the HIIN database, it's going to look and feel a lot like the HIIN work plan. So while I bring that up here for you, I just want to take a moment to remind everyone that your work plans are due by June 14th. And so if you haven't had an opportunity to do that, it might be a great time to do that and also complete your health equity organizational assessment at the same time. So I have the Compass HIIN hospital portal up right now. And as you can see, I have a guest hospital, so this is not real data for anyone. And you'll notice down here in the Compass HIIN report section, there right below the view and edit the work plan is the view and edit the HEOA. And I'm going to go ahead and click on that. All right. And hopefully you're all seeing this right now. And so it's very similar look and feel as the work plan. As you'll see right here, up here is the Health Equity Organizational Assessment. And there's 7 tabs with the Health Equity Organizational Assessment. And each of those correlate with the categories that we just discussed. So here's the first one, the second, the third, the fourth, the fifth, the sixth, and the seventh. And you'll notice that they all say incomplete right now. And so what you will do is you will open up your first one, and I think it automatically opens when you get into the portal, and it'll provide you with the intent of the category. It gives you tips and tricks and best practice recommendations, and then it asks you your questions. And so, for example, for this first one, around hospital uses a self-reporting methodology to collect demographic data from the patient and/or caregiver. So they say hospital uses self-reporting methodology to collect this. And your answer to that, as well as all race and ethnicity categories should at a minimum roll up to the OMB categories, should be collected in separate fields. And you should engage your patient and family advisors in the collection of real data to gain their insights and feedback. So if you do real data, you would click yes. And you'll notice a new box pops up. And it's asking you whether or not you meet the mid-level or intermediate criteria. So they're saying that yes, you meet the basic or fundamental, but then do you also collect real data for at least 95% of your patients with opportunity for verification at multiple points of care? I won't read all of these verbatim to you. I kind of want to just show you the functionality because I think you'll need to work through each of these independently and understand sort of your unique situations at your own organization. But let's say this guest hospital, yes, they do meet the mid-level or intermediate level, so they will click yes. And now we get to the advanced level. And so you're meeting the prior to, and now you're looking to see if in fact you use self-reporting methodology to collect additional demographic data. And those are the things we talked about. So you're going beyond the actual real data. So you're looking at disability, sexual orientation, and such. Let's say this particular guest hospital has not met this level and no is clicked. So it shows complete up here. So once that's complete, you can go ahead and just close that one down. It stays complete. And now you're going to move into the hospital provides workforce training regarding the collection of self-reported patient demographic data. And again, this is going to look very familiar to you. Each time, it's going to show the intent of the category, why it's important, what it is that you're trying to accomplish, and then you're going to answer whether or not you do this. So our workforce trained regarding the collection of patient self-reported real data. And let's say for this organization, yes, they do that, but when it gets to the mid-level or intermediate, which means that they are evaluating the effectiveness of workforce training on an annual basis, they don't quite meet that yet. So it would be no, and you see that it doesn't go to the next level, which is the advanced level. and it shows complete. So it will always show complete at the highest level by which you have answered. So once that's complete, then you can close that. And this will follow the same process through each of these. So you would be verifying the accuracy and completeness of patient self-reported demographic data. One thing I would like to point out, and I'm going to actually utilize this, is that anytime that we want you to reference another document, you can actually click on the resource, which is really nice. You don't have to have yet another document in front of you. You can click on the resource and it'll take you actually out to the reference page and give you the tools that you need or the references that you need to be able to assist you when you're reviewing the intent of that. And then you can just pop back over to your HEO page. And let's say for this particular one, this hospital doesn't meet the basic or fundamental. Again, there are no right or wrong answers. They click no and it goes to complete. So before I go through any more of these, I just want to take a moment and see if there are any questions in the chat meeting or in the chat box. Hi, Lana. Great question for that. At this point in time, there is not a print option once completed. That's something that we will be working on. And I think that that's a great segue into actually the next slide. Great question, Kristen. So I'm going, okay, I see several questions here. So I'm going to go into the next slide and then I will come back and answer these questions for you because it actually may, okay, great. Great question, Sandy. Robin, great, thank you. So really the intent and value of the HEOA is to collect a baseline. That's really what it's serving. And then it will allow the baseline to drive awareness. Some of you may think you have certain disparities, maybe you aren't aware of the disparities, maybe you are, but this will help allow the baseline to drive awareness and then use the data to drive change. And that is a future enhancement with this. Right now, we are really at the collect a baseline level, and the overall goal is to ensure each patient receives high quality, equitable, and safe care. So I hope that that kind of helps a little bit. It's really about starting somewhere, creating a baseline so that you can, be aware, understand your population, and then, of course, intentional use of the data, and again, receiving high quality, equitable, and safe care for all persons. I'm going to go back to the chat here real quick. I'm going to read a couple of questions here. Lana, print the final product once completed. No, not at this point in time. What will the data in the hospitals are completing be used for? Kristen, again, this is something that we are asking hospitals to consider participating in. I want to emphasize that it is not mandatory. It is just to be able to set a baseline, and the data will be utilized as part of collecting data just like we do for PFE. So those of you that have been answering PFE related questions, this will be very similar. So it's establishing a baseline and then creating tools and resources. Angie, who all in the organization should be involved, and Tanya, the same thing. I think that you need to involve the persons who are part of your IT staff, your EMR, your registration, anybody that has some of the information, perhaps anything that you do around training of your staff around health equity, those of you in quality, do you utilize any of your real data to stratify your patients or see where there might be opportunity? So there may be various people within your organization, and each organization is different relative to who you might need to tap into to complete it. Robin, I think I answered your question. The goal of completing this is really to just create a baseline and have an understanding of where you're at. And does this have to be updated every month, Sandy? No, not at all. I would say that we're just doing a baseline right now. And then we would want, from there, you could utilize this tool moving forward, but really it's just to find out where you're at right now, and more information will be coming. And should administrative team be engaged in the assessment? Yes, Lana, I think that the administrative team should be engaged in the assessment just by nature of the questions. And we do have, in addition to the assessment itself in the portal, we do have some information that we can send out to you. And I think that that's a great segue into the final slide here. Oh, when is the target date for sending the data out to hospitals that participate? We are assessing that right now. I wanted to share with you, and this might be helpful to you. So when this was first discussed within the affinity group, this began last fall. And quite honestly, our HIIN wanted to kind of see where things were going and see what other HIINs were doing relative to assessing their hospitals around health equity. And some of them were doing surveys via phone, some were doing written surveys, email surveys, SurveyMonkey. And we really wanted to make sure that we sort of rolled this out in the right way. And that's why we wanted to build it into the portal so that it would look similar to your actual work plan. And so we are, I would say, probably a couple months behind other HIINs relative to how they're utilizing the data. It's to be determined, but I would suggest that you know that we are working on it, and that the information will be able to be printed. And then really it's around not so much a comparison to others as it is for yourself. So, you know, it's really important to think about this as an individualized report, just like we don't share with you PFE data across the entire continuum right now necessarily. So I would encourage you to kind of think of it like that. It's for your own internal use. Sandy, suggestions of where to gather this data. It is within, I would say you need to engage your administrative team. I think I talked a little bit about that before. I think that it's going to vary from hospital to hospital. And I think that when you start getting into it, you're going to have to see how much of that is collected upon admission to your hospital, how much of that is transferred over. Are you collecting it at different parts of the stay if they're transitioning from one area to another? And yes, these slides will be available post-webinar. Jackie? Okay. Shut this down here for just a second in the chat. So, I just wanted to remind you that this is something that our team is working on very closely with their hospitals. I know that Lana and myself and Ashley and Sandy and Jennifer, we are all of your team of clinical quality consultants, have reached out to some of their hospitals and asked them to complete this, and also are offering up some tutorials if you need them. Feel free to reach out. We're happy to hold a webinar, a Zoom meeting where we can actually walk you through it and help answer any questions that you have. You know, on behalf of myself and my wonderful peers here, I just would like to ask you to consider completing the HEOA. Preferably this would be done within the next month. However, that is, you know, not something that is mandatory, and we're here to help. Feel free to reach out with questions about it, provide input on what you would like to see with this. You know, this is a test of change as well. So let us know what you think about it. Let us know how you think you would want to use the data. And then additional information that piques your interest around this very important topic. We have a lot of things around health equity. It can become quite overwhelming. So I wanted to just really stay focused on the assessment itself today. But if you have any questions or would like any additional information about health equity, please don't hesitate to reach out. And I think that wraps up my time. If you have any additional questions, please feel free to put them in the chat box, and we'll try to answer if there's time at the end of the entire session. And yes, these slides are available for everyone. Thank you so much for your time.
Thank you so much, Michelle, for sharing that information. It is now time for our final session on achieving sustainable healthcare transformation through community and hospital partnerships. It's my pleasure today to introduce Carrie Harbaugh, Sarah Meyer, and Angela Crozy-Visser, the speakers for this final session. Carrie Harbaugh serves as the coordinator of the Family Resource Center at the Guttenberg Memorial Hospital. She is chairperson for the nonprofit Families Helping Hand and council member for Community Partnership for Protecting Children and Prevent Child Abuse of Iowa. Carrie previously worked for Unlimited Services in Guttenberg and understands the importance of high-quality vocational and mental health services and supports. Sarah Meyer is the ambulatory quality coordinator at Guttenberg Municipal Hospital. She has an associate's degree in medical assistance from Kirkwood Community College. Angela Crozy-Visser is a community health planner and grants manager at Community Health Partners of Sioux County. Her role includes building healthy communities through community collaborations, grant writing, and most recently, working to bridge community efforts in clinical practice. Prior to her current role, she worked as an education program director and in the medical service industry. Angela graduated from the University of Minnesota in 2005 with a master's degree in public health and community health education. Welcome to our very first presenter, Angela.
Thank you so much. I just want to check in and make sure everyone can hear me all right.
Yes, you sound great.
Okay. So thank you so much for the opportunity to come and share a little bit about our SIM project. So my presentation is entitled Building Bridges in Sioux County. But before I get to the building bridges part, I just wanted to clarify a little bit about where Sioux County is. Sioux County is located in the northwest corner of Iowa. We're not the northernmost county, but we're close, and we border South Dakota on the other side. In our county, we have 4 critical access hospitals, a community health center, and I work for Community Health Partners of Sioux County, which is the public health provider for the county. So I'm going to talk today about building bridges. And if you want to move to the next slide, I wanted to share this picture, which is an actual picture from Sioux County. And here is my illustration of what happens when bridges are not in place. So in 2016, in Sioux County, we did a community health needs assessment in partnership with all 4 of the hospitals. So we all worked together to identify needs. And one of the needs that we identified and we heard a lot about is the fact that we have a lot of really great resources in Sioux County, great healthcare providers, great healthcare provider organizations, a lot of social service agencies. But what we heard was that our services weren't always coordinated. People weren't always able to access what they needed when they needed it. So we aren't always able to help people get from one side of a need to the next. And what happens when they can't access those services is this. And in fact, we have a name sometimes that we use for those people. Sometimes we call them maybe a train wreck. But one of the things I want to point out about that is it's actually not really an issue with the train. It really is a matter of those bridges failing. So this is a picture of a bridge that failed. We've all had someone in maybe our office or in our organization or someone we've worked with in some way who had a need or maybe multiple needs, but they just were not able to get what they needed when they needed it. I'm going to share 2 examples today of encounters that some of our care coordination team has had. So the first is a woman who came to our office and talked with one of our care coordinators. She was employed, but was having some struggles with food and with finances. And actually, she was employed in the healthcare sector. And so I think she felt a little more comfortable maybe approaching public health than she did looking to one of the care coordinators in the healthcare system. Her husband was not working at the time because he had had some health problems. She had some outstanding healthcare bills, and they were having trouble accessing food. Well, our care coordinator worked with her to try to address those needs, and I'll talk in a minute about how we did that. So hold that story, and I'm going to give you one other story. And this is the story of a woman who has diabetes and was having a lot of issues with low blood sugar. She had never been through an official diabetes education process, partly because of high deductibles, and partly just because she had a hard time getting into the office when there was time. And we were just talking about health equity. There were a lot of other things, including language barriers, that were keeping her from accessing that service that she really did need because she was struggling with that. If you would move to the next slide. So our solution to this issue of not having bridges was to build bridges. And one of the ways that we built bridges was trying to connect primary care and connect to community resources. We did this in a variety of ways in Sioux County. We placed care coordinators in each of the clinics, and we also have a few that really were targeted toward really high needs clients that are located in our public health office. For those two stories that I shared, here is how we connected primary care and community resources. The person who was struggling to meet food resources, she was also over income for food assistance, but our care coordinator was able to meet that need temporarily, getting a food box from a food pantry to help meet that need in the short term. In the long term, maintained a relationship for a period of time. And what happened is that this woman ended up leaving her current job. Her husband ended up having a lot more issues with health, but she was able to obtain another job. In the interim, they received food assistance and some other help to get them sort of through that period of time. And she was able to find another job that did have insurance coverage and to help them become more stable. So the long-term relationship with a care coordinator helped to bridge that period of time when they needed to address some very specific food and finance needs. Now, I'm not saying that everything turned out great. And in fact, we don't have any long-term follow-up for that particular client. But in the interim, we were able to bridge that need of food and of addressing some of those financial needs particular to receiving healthcare by building a relationship and by being that connecting piece. The other story with diabetes education, we were able to connect our care coordinator, who does have a background in diabetes education, with this patient. She was able to visit her in her home and provide some really basic diabetes education, was able to see the sorts of foods that may have been contributing to these extreme low blood sugar episodes. And was able to do that even though for the past 3 years, she hasn't been able to do this diabetes education process. Because we were able to meet her where she was and bridge that gap, she was able to learn a lot more about how to better manage her disease. Next slide, please. So those two stories, I hope, illustrate that this isn't a simple process. It's not a silver bullet sort of thing. It's not as if this is going to meet everyone's needs all the time. But a really, really important piece of it is all of the different entities that are involved. So this is just a picture of some of the people that are involved in our SIM Community Care Coalition in Sioux County. As I mentioned, we have care coordinators that were in place at each of the clinics and also at Community Health Partners. And we really have a ton of great community providers. And I'm really excited to hear from our next panelists also, because I think every community has providers and organizations who are doing a lot of really great work. And sometimes the challenge is, how do we build those bridges, not just for those individuals who are in need of services, but how do we build bridges between those providers I don't know about your community, but in my community, that can be a challenge. It's not often that we have opportunities to sit down with people who aren't in our field, or people maybe who just work in organizations that we are not a part of. We tend to work very much in our own organizations. So the other piece of our project really was about building bridges between organizations. So when I asked our steering team about what the biggest successes were for our SIM Community Care Coalition project, one of the steering team members pointed out that one of the biggest successes was simply the fact that we met together on a regular basis and were able to put aside momentarily our own organizational agendas and really think about the population of Sioux County and what needs there were in the county. And that happened because we did meet together on a regular basis and we identified those shared priorities that we could work together on. And so as much as it was very important to us to be building bridges for those individual needs, we also were very intentional about building bridges between organizations. Next slide, please. So as a result of this project, here are some of the things that we are able to show. In 2018, our care coordination served 267 clients through care coordination and made 477 referrals. So that's referrals to a variety of resources, and the highest number of those were related to pharmacy needs, to insurance needs, to social and community context. That might address isolation, social support, needs of maybe elderly people. I know that for sure some of those had to do with finding housing, long-term care sorts of things. And that is outside of the next category, which was housing and rent needs. A really big question that we continue to ask ourselves is what would happen if we weren't there? And what happens if there's not someone doing this work? Just remind yourself of that first picture that I shared. So as we move forward, we want to continue to build bridges for individuals and between organizations. Next slide, please. And as you can see, I like pictures of bridges. And this one for me signifies that we're not just bridging these two places, but we really are building bridges and communication between organizations. So our goals moving forward include continuing to contribute to improved communication and improved networking between healthcare systems, and not only between healthcare systems, but between healthcare and social services and public health. Creating space for sharing ideas and strategies for prevention and clinical care. One of the things that our steering team members appreciated, and it's similar to what we're doing here today, is the opportunity to hear what is working in other places, to share ideas, to have a safe space to brainstorm, and to feel like it's okay to look at a problem and look at multiple ways of addressing it. And also we want to strengthen the infrastructure to identify and address those community health needs. So we are working together again to complete some joint priorities for our community health needs assessment. And that is really what has driven a lot of this work, is looking broadly at our community and saying, we know there are a lot of needs, and we know that each healthcare organization, each organization is very unique and will have different ways of addressing those. But there are also some things that we can do better together. And so really focusing in on those places where we're better together. So if I were in person with all of you and you were sitting at tables, one of the things that I might ask you to do is to talk together and to try to find one thing that you all have in common, or maybe three things. You've probably played that game before, but I think it's a really powerful illustration, because sometimes we tend to think only in our silos, and we tend to think only about what our organization needs or has to give. And sometimes all we need to do is reach across and find something that we have in common with one another, and we can build a bridge. Next slide. If you have any questions about our project, what we did, some of our results, there are a lot of other pieces to what we have done in our community that I didn't get to today, didn't have a chance to mention, but I would be happy to share those with you. Here's my contact information. And again, thank you so much for the opportunity to share just a little bit about our process and project.
Thank you so much, Angela. If anyone has questions for Angela, please pop them into the chat box and we'll go ahead and answer those at the end of this presentation. So Carrie and Sarah, I will hand it over to you.
Thank you. I'm Carrie and I work at our Family Resource Center, which is a department of our Ventnor Municipal Hospital. My name is Sarah Meyer. I also work at Cornerstone Family Practice, the clinic, the primary care clinic, and we are also a department of the Ventnor Municipal Hospital. Next slide. Gunberg is located up in northeast Iowa along the Mississippi River. We're about a town of 2,000. Our hospital is a 25-bed critical access hospital. We have 3 clinics that make up the Cornerstone Family Practice. We have one main clinic, and that's in our Gunberg location right within the hospital. We have 2 satellite clinics. One's in Edgewood. It's about 25 miles away. We have another one in Garnavilla. It's about 11 miles away. We employ 3 physicians and 5 nurse practitioners that make up the staff for our clinic. Next slide. Next slide, please. Okay, so in the last department is the Family Resource Center, which is actually located off campus. So we're in downtown, the business district of downtown Guttenberg, a few blocks from our hospital and clinic. The main goal of the Resource Center is to connect clients and patients with resources that serve our area. So in the rural area, access to services is one of the main barriers because a lot of the services that come to our county aren't located in our county. They're coming from outside of the county. I'm going to try to adjust the volume just to hear me a little better. So on this slide, we talk about some of the services that we do in-house. We do have we have a mini food pantry, we have a clothes closet, we have a variety of other furniture, warranties, and offers. But by working with our clients and patients on an individual basis, we assist them in creating a plan that helps them prioritize their needs. Examples might be with like housing needs, food, clothing, employment, utilities, healthcare, medication, safety, mental health, transportation, substance abuse, and financial budgeting. This is documented for communication for our entire health team, and it's tracked and measured so we can see progress in the clients that we're serving. Next slide. On the next slide, it's really a key component to the Resource Center is our collaboration with agencies, with outside agencies and organizations. I'm the only employee that from the hospital that works in this department, so there's many other people that are there on a daily basis, but just the microphone a little more. There's many people that work out of there in an individual basis, but by us providing this unique hub, it allows agencies to be able to use space and work together for no cost. We work closely to build these relationships and keep track of the current programs. We offer space to families just to build to break any barriers. Program applications we can help fill out. We have MOUs, established memorandums of understanding with schools and other organizations so that it kind of breaks down that communication barrier. And then we also have releases to help with the families so that we can help better assist them when their needs come up. Next slide. The next slide is our nonprofit that also works out of the Family Resource Center, and this is called Families Helping Hand. It has its own 501c3. It was established about shortly after the Family Resource Center was developed. It's a grassroots group that focuses primarily on prevention and education, but mostly it really does give us that financial flexibility to come up with solutions that address gaps in services. Through grants, endowments, and then donations, we're able to think outside the box to create solutions for the needs of the people that live in our communities. Some examples are listed, like community-based mentoring programs, teen support. We have a wants, needs, and offer program, hygiene kits, healthy meals education, school supplies, Christmas for kids. Those are a few of the things, but it really just gives us that another resource of financial flexibility when we're trying to come up with a solution that we know might work. Next slide. On the next slide, another way that we build our volunteer base at the Resource Center is to connect local people with local groups for support. We include them as an important role with our patients, and the more support and the stronger the support system, the better the outcome for our patients. Next slide. On this slide, another important partner is our school. Our schools make many referrals to our resource center, and then we're able to connect their families with some of the social needs that their families may have. We also partner with them on some of the things that we have as common goals, such as suicide prevention, prescription drug education, substance abuse, hygiene, things like that. And the last slide for me is the collaboration with coalitions. So our county coalitions we work very closely with as well. We've been able to do several different projects with them. There's a link on here that would give you an example of one of the things that we recently did for prevention, but they also allow us to build a very strong volunteer base because they're the faces and people in the communities that have passion for many of the projects that we have as a part of our goal, like substance abuse or mental health. So by partnering with them, it really does help us. Kind of summarizing, when we identify the social determinants in our patient or with our patients, our clients, is just the first step. So we have a tool established to do that. But if we didn't have the partnerships and actively learning and working with the agencies and programs on a regular basis, it would be really next to impossible to make like a positive outcome, because through the referral and the tracking system, that allows us to measure like the outcomes and better serve our patients. Next slide. Now that you've heard about all the great things that are happening at the Family Resource Center in our community, I'm going to explain on how we continue to integrate Carrie's role as a community health worker within the walls of the hospital. First off, our clinic is a patient-centered medical home. We've been recognized as a patient-centered medical home since 2014. So population health and care coordination is really not new to our clinic. But identifying those social determinants and that referral process to Carrie is new and something that we continue to work on. So this was basically the start of us utilizing the Family Resource Center within our practice for care management. For quality, we're slowly integrating Carrie and the community health worker into the day-to-day operations of the hospital. Carrie is now attending all of our monthly staff meetings. She reports on current classes, support groups, community-wide activities, anything that's happening at the Family Resource Center. We hang flyers in the exam rooms regarding these events or what's going on. This is a good reminder for staff to know to relay that information to patients, as well as patients while they're waiting in the exam rooms. They can take a look and read and see what's going on in the community. Carrie also attends our transitional care coordination team meetings. That's a multidisciplinary team of inpatient, ambulatory, rehab, quality employees, social workers, and of course now Carrie. This team is focused on specific patient case studies across the care continuum. Everyone plays a role in the patient's outcome, and if we work together, our hope is for better outcomes long-term, as well as to increase that patient satisfaction. So we're all working on the same page with the patient. Carrie's also attending our quality meetings at the clinic. We meet monthly to work on patient-centered medical home, our ACO work through Wellmark and Mercy, the Medicare ACO, rural health requirements, and any department-level quality measures. Anything really patient and population health management happens at this meeting, and Carrie is now involved in that as well.
Two areas that we plan to focus on in the near future are patients that are high cost utilizers in our ACO. Our health coaches have ongoing contact with these patients, but we'd also like to have Carrie, as a community health worker, have continued contact with them as well. We think we should start to question, does the patient have any social determinants that are contributing to their medical conditions, such as do they have transportation issues? Do they have trouble paying for food, heat, or air conditioning barriers? All of these really could be contributing factors to their medical condition. So those we need to start looking at as well. Another area that we plan to focus on is our newly diagnosed cancer patients. Of course, your initial focus is on the medical portion, but we also need to start having discussions on the mental, social, as well as financial effects this type of diagnosis will have for patients and their families. The community health worker is that link that we're missing to connect resources to the patients, agencies, anything that is available in our community that will help these patients with this type of diagnosis. Future reimbursement, as we know, we're moving to value-based payment system, so we're shifting that reimbursement from process to outcomes. We realize that we just can't treat the patient within the four walls of our hospital anymore, that we're responsible for our community. We need more engagement from the patient, which will in turn have better disease management outcomes. And earlier identification of health issues will result in long-term healthcare costs to lower those. For the SIM grant, we knew we had a great resource in Carrie, and actually what the Family Resource Center was doing, but we needed to figure out how to better utilize her role in the hospital. And by us receiving the SIM grant, that has helped us with that. We received grant funding through the SIM grant, the community models at work. We decided to use that money to expand our IT capabilities for better care coordination. That was just really the jump start that we needed. This is what we did with that grant money. First off, we purchased a cell phone for Carrie. Previously, she was giving out her own personal cell phone number to patients for contact. This has greatly increased confidentiality. We're able to capture accurate data and improve response time for her. We also purchased a laptop, projector, laser pointer, some this technical equipment to be used at the Family Resource Center, as well as any educational classes that Carrie may take out into the community and into the county. We purchased 9 tablets. We have them located at our 3 Cornerstone Family Practice clinics, our emergency room, our patient care unit, and at the Family Resource Center. These tablets we're using to survey our patients. We developed a 10-question survey regarding social determinants. The survey will identify patient needs, but also community-wide needs, because we are collecting from a wide range of patients. So that data-driven outreach to target what our community needs so we can make the biggest impact on population health. The surveys are confidential. The results do not go into our electronic health record. They go directly to Carrie at the Family Resource Center. If a patient wants any follow-up from the Resource Center from Carrie, all they have to do is include some basic demographics. Carrie will reply back to them with any questions that they have within 48 hours. If there's an urgent need within this survey, it says to talk to the provider at their appointment. It's handed out to every patient, including minors. The survey is available on paper, in English, and in Spanish, because we have an older population and sometimes they get a little intimidated by the iPads, so we have it on paper form as well. But patients can always decline. If this is something that they don't want to take, that's fine. The survey is customizable, so depending on what's happening in the community or our location, we can change out the questions. For example, if there's some kind of natural disaster, like flooding or something like that, we can change one of the questions to address that to get real-time feedback back from our patients on what resources that they may need. We started offering the survey to our patients back in March of this year. To date, we've had a great response of over 1,000 patients taking our surveys, which we're ecstatic about. For the data, The two biggest needs of the community that we have found from this are mental health as well as food insecurities. And to address those, for the mental health, we've integrated 2 licensed independent social workers within the family practice clinic. So they're seeing patients there as well as they're going to our long-term care facility. They're currently available to see patients 4 days a week, including Saturdays at our main clinic and 1 day a week at the long-term care facility in our town. Our goal in the near future is to expand those behavioral health services to one of our satellite clinics in Edgewood, which is located in an adjoining county. For food insecurities, we have worked to really increase the awareness of our community-wide resources. And by doing that, we are hanging additional flyers in the hospital, and we're utilizing social media. We are currently promoting what we have in our town of Gunberg is a monthly mobile food pantry where anybody in the community can come and get some resources to help them with their food needs. While completing the survey, we've had over 130 patients request assistance. So that means they've left that demographic information that I was talking about within that survey, that they need assistance regarding one of the social determinants within the survey, in which Carrie will contact the patient within 48 hours to get them linked to help with their needs. We also trained Carrie on our electronic health record. She's now documenting her interactions with patients into our Epic computer system. This has integrated those social determinants into the patient's electronic health record that is shared by all departments of our hospital. So since we've started doing this, it's resulted in a reduction of duplicated services. So Carrie can see what she's doing at the Family Resource Center with the patient. She can see what we're talking about when they're in for an appointment, and vice versa. If our physician is in the patient's chart, they can see what Carrie is working on as far as resources community-wide. So we're not duplicating services any longer. There's better care coordination, as well as that standardized referral process to Carrie. So any type of referral that we do, we treat her referral just like we would an oncologist. Same process, same everything for our staff. We've developed an electronic tracking system. Currently, we're using a Microsoft Access product. This allows tracking of individual patient needs as well as community needs or gaps in care. We can now generate reports off of this system. Prior to this was all a manual process. We also work to improve our community resource guide. Previously, this was just on paper, and as we all know, anything that's on paper is very hard to maintain and to keep current. Things are always changing with agencies and what is offering or being offered in our community. So it's very hard to maintain. Now this will be available electronically on our hospital website, making it more accessible for our patients and easier to keep up to date. So what our next steps are going to be after this? As I said, we just started the SIM grant and collecting data. We started that in March. So we're really new and aren't able to, maybe look at how many outcomes or measures to see if we're really improving anything as of yet. But our next steps are to continue to educate and build those partnerships in our service area around the resources and the services that are available. We hope to increase the efficiency and to obtain substantial data to utilize in future grant opportunities and partnerships. And as always, we'll continue to identify gaps in social determinants, gaps in care, and how they link back to the medical outcomes for our patients. And to continue to integrate Carrie in that community health worker role within our hospital and across the care continuum. Next slide, please. So the impact on our community. Our annual activity report, we've had over 4,000 contacts, and that was when we were doing everything manually. So we expect our contacts to increase because of the accuracy of tracking all of these things electronically now. Last year, community benefits, we provided over $65,000 as community benefits for that year. And all of this would not be possible without the volunteers that help Carrie at the Family Resource Center. She is the only paid position that we have at the Resource Center. So she has lots and lots of great volunteers that make all of these things happen community-wide, which is all collaboration through the churches, schools, and all those other agencies that work with her. Next slide, please.
Thank you for allowing us to share this information with you. If you have any questions, we're happy to answer. I did see a question about the survey, that what we use, and we do use SurveyMonkey. And the surveys just then roll over to myself so that I can follow up immediately.
Any other questions for our speakers today on this session? Well, I'm not seeing any questions come through the chat box today, so thank you very much to Angela, Carrie, and Sarah for your time presenting on this webinar, along with all the rest of our speakers. We really appreciate it. When you receive an evaluation email at the end of, by the end of the day today, if you would please fill that out, we'd really appreciate it. We do use that feedback to help create and craft our education moving forward. This concludes our program for today. Thank you so much to everybody for participating, and we hope you have a great afternoon.